Okay. All right. Good afternoon, everybody, and welcome. It's really wonderful to be here with you all today. My name is Sharona Ben-Haim. I am an associate professor and a neurosurgeon at UC San Diego, and I'm also the director of our epilepsy program, and it's also great to see some familiar faces in the room here. And I have the really fun and exciting task today of discussing one of the coolest new therapies that is right now out there in a trial, which is cell therapy for the treatment of epilepsy. We've purposefully left a lot of time at the end of this talk for Q&A, so hopefully we'll have an interactive discussion. Okay, let's see. All right, so you've probably heard this. If you've been in this room today, you've probably seen this in pretty much everybody's talk, but it really can't be understated. You know, we're very lucky with epilepsy. You know, epilepsy is actually the fourth most common neurological disorder in the U.S. Affects really millions of people in the U.S., but luckily, about 70% or so do quite well with medications. And they're not patients that we really need to consider surgery for. However, there are 30 to 35% of patients who meet what we call drug resistance, who have drug-resistant epilepsy. And that has a very, you know, what is drug resistance? I think this is a really good question, and it's one we grappled with for a long time as a field. Does drug resistance mean you've tried every single medication out there? No, because that would be really hard to do, as evidenced here, actually. I love this slide, and thank you to Neurona for providing some of these slides. There are, at this point, about 46 anti-epileptics, and every year we see a growing number of anti-epileptic medications out there. So it's not feasible or ideal for any one patient to have to try so many of them. Furthermore, we have really good evidence that shows us that, you know, patients, about 50% of patients after they try their first medication become seizure-free, another 15% with their second medication, and once you get to the third, fourth, fifth, sixth, seventh, eighth, 20th medication, we're looking at more like 3%, 2%, 1%. And so this led to a definition that I think is really important for everybody here to know, which is drug resistance really means after you've failed 2 appropriately chosen anti-epileptics, either in monotherapy or in polytherapy. That doesn't mean that you shouldn't continue to try others. Of course, certainly you should. And the patients who actually come to our epilepsy center are patients who have usually tried 5, 10, 20 medications in reality. But it's a good idea after failing to So overall, when we think about epilepsy, we still have a lot to learn about it as a field. We still don't fully understand what's going on in the region of the brain where seizures start in great detail. But we do know that, or we do believe and have some good evidence that shows us that in that part of the brain, there's an imbalance of activity. In that part of the brain where seizures are coming from, there appears to be an imbalance of excitation and inhibition, with too much excitation and not enough inhibition. I can kind of describe it to my patients, it's kind of like sparky tissue. It's part of the brain where things that regulation that we normally have is imbalanced. And so the exciting thing about cell therapy, what cell therapy is us injecting cells into the brain that produce an inhibitory neurotransmitter called GABA. So we are actually injecting cells that produce inhibition, and the goal here is to restore the balance between that excitation and inhibition, specifically in that region of the brain where seizures are starting. So you'll see here NRTX 1001 is actually the cell line that's currently being used. This therapy is being brought to market by a company called Neurona that's really taken on this Herculean effort to try to bring this as a therapy to our epilepsy patients. And they're the ones who are really administering this trial along with the FDA. So these cells, as I mentioned, produce GABA, which is a neurotransmitter that causes inhibition. You can kind of see what these cells look like. Interneurons, or these cells that produce GABA, are cells that we have throughout our brain. And in regions where seizures start, we see cell loss, some of all types of cells, but specifically also of that type of cell, that GABA-producing interneuron. So where do these cells come from? Where do these GABAergic interneurons that we're injecting come from? They come from stem cells. Stem cells there are different origins where stem cells can come. We now have technology that allows us to actually take an individual's own skin cells and turn them into stem cells that then can become a whole variety of different other cells, including these type of inhibitory interneurons. And these cells can also come from an embryonic cell origin that can then turn into an inhibitory stem cell. And so you can see here, a stem cell can produce all sorts of different kinds of cells. And in this case, for this trial, we're using stem cells to create inhibitory interneurons. We're creating young inhibitory interneurons because those young cells better incorporate into the brain and make those connections in the brain that we want them to make. I won't go into great detail about the manufacturing process, but we can certainly get into some of that into the Q&A. But basically, from these cell lines, just from one individual cells, we can get many, 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 many cells. And then we differentiate them, or actually Neurona differentiates them into these GABA inhibitory interneurons, and then they are purified and tested, and then they then go out for implantation. And that process of purification and testing is important. So these specific cells that we inject, it's a one-time therapy, at least at this point. That's how it's conceived, and that's how it's been borne out in the animal testing. It's a one-time injection of cells that then integrate into that part of the brain where they're injected and stay there for life. It is important. There's a lot of kind of misnomers about this therapy. A lot of people will call it stem cell therapy or think that we're injecting stem cells. But it's important to remember we're not injecting the stem cells themselves. We're taking a product that comes from a stem cell and becomes a very specific type of cell. And so there are actually no stem cells in the final product. And we have now, I'll show you a little bit of the preclinical animal model testing that shows that these cells are administered and really stay where they're supposed to stay and don't grow beyond where we want them to grow. And they've proven safe in many versions now over many, many years of toxicology studies. And we have really nice efficacy in animal models of epilepsy, with a lot of animals actually becoming seizure-free. A lot of this was done in mice. Also, damage to the temporal lobe was reduced, and other things like learning and memory were actually improved in some of these animal models. And I'll show you a little bit of that data here from this publication. Very pretty pictures where we can get really detailed understanding of how these cells integrate and where they go specifically in these mouse models. And so here we can see this red staining of all of the cells that were injected. And then here we can see the stains for cells that are producing those inhibitory neurotransmitters that we're looking for specifically. Here, can you see my cursor? My cursor showing up? Okay, great. Here we can see this is a mouse model of epilepsy. We actually inject something called kainate into the hippocampus to create a model of epilepsy. And when that happens, we see these morphological changes in the hippocampus. And we can see here that with injection of these cells, it still looks different from the pre-epileptic mouse model, but it looks more normal than without injecting these cells. So some of the damage that's done with epilepsy, we think, is actually reversed or not made to be as prominent with these cells, which appear to be protective from that. And then here we can see a deposit after 1 month and after 3 months, and how these cells spread, but only in the region where we want them to spread and integrate. Here's some of the data from the mouse models. Here we can see vehicle just means that a placebo was injected, just the actual vehicle that the cells come in and not the cells themselves. And then we can see, this 0 is a baseline seizure, baseline level of seizures. And we can see that, in these animals, kind of seizures are all over the place. They're at 1 to 2 months, at 5 months, and at 7 months, they don't really change. This is when the cells were not injected. Here in these two lots, the cells were injected, and we can see at 1 to 2 months, nothing really happens. But at 5 months and 7 months, in both cases, we can see a significant reduction where a lot of these dots are now here at this negative 100%, meaning that these mice here are seizure-free. Still some stragglers up here, but some really robust results in these preclinical models, which are very encouraging. So just a summary of those preclinical results. These are cells that are derived from stem cells, and they appear to be effective in these mouse models. Again, safe in the animal toxicology studies, and we see that there's not migration around where they were placed. That's really important to know, that they stay where we want them to stay, integrate, but don't migrate. So now moving on to the human study, it's been a very exciting thing to be a part of. We have gotten a lot of, we are a part of the study at UCSD, and we've gotten a lot of, attention. There's a lot of media attention around this. So far, in total, around the country, I think 13 patients have been implanted. We're going to do patient number 14, actually very soon. And we've implanted several of them at UCSD. And it's pretty exciting. I'll talk a little bit about the results from that study in the next couple of slides. But we really have been encouraged so far. We haven't seen any serious or severe adverse events specifically related to the cell therapy. We haven't seen any significant surgical complications. So far, we've seen pretty good effects on seizure control. And we've actually also seen some interesting improvements in some of the cognitive testing, which I'll go over. So right now, there's actually 2 specific studies going on. So these studies all should qualify. All really are for patients who have mesial temporal lobe epilepsy. That is the most common place for adult onset epilepsy, and that's where an epilepsy involves structures like the amygdala and the hippocampus and some of those surrounding regions. In the first 2 cohorts of this trial, it was specifically patients, it was very, very, very specific patient selection, patients who had mesial temporal lobe epilepsy and also had a finding on their MRI specific called mesial temporal sclerosis, where we actually see some morphological changes on that MRI. We see some scarring in that hippocampus. Although now there's another cohort where there's still coming from the mesial temporal lobe, but there isn't any sclerosis on the MRI. And there's actually also a phase of this trial now that specifically is addressed for patients who have epilepsy coming from both mesial temporal lobes. And that's a really important arm of this trial because that's a subset of patients that we currently have pretty limited surgical options for. It is important to know that patients are on immunosuppression for 12 months after this implantation. That's pretty much standard of care for any cell therapy trial. And that's something that is really a part of this trial at this point. As far as the actual surgery itself, it's very similar to a laser ablation. When I perform this procedure, I pretty much set up the room and our equipment almost identical to how we would do a laser ablation. And I'll show that in, actually right here. So to do the surgery, just like a laser ablation, we don't shave the head, even though this picture is a 3D rendition of a patient's head with no hair. But we can get away with actually performing an extremely minimal head shave. The incision is really a tiny incision. It's probably about 7 millimeters if I had to quantify it. And then we make a very small opening through the skull, and then we implant this catheter, which is 1.65 millimeters in diameter, directly into the head of the hippocampus, and then we inject cells along that trajectory of the hippocampus. And you have to squint a little, but you can kind of see these white dots here. Those are the tiny little cell deposits in that area. Really probably amounts to 1 drop of liquid, but in that drop are millions of cells. So going back to this study design, actually. So let's move on to results. So this data has now been presented at some of our national conferences, and we now have really robust long-term results on the first 5 patients implanted. And we can see that after 6 months, at this point here, we saw 80% of patients with greater than 50% seizure reduction, and we saw some of the patients with significantly more than that. And then once we go on to the long-term cohort, we see 97 to 99% seizure reduction in these patients who we have now followed for almost 2 years. And these patients are now off their immunosuppression and still benefiting quite greatly from this therapy. We did see in all of this cohort seizure freedom from disabling seizures in 3 out of the 5 subjects. So adverse events, when reporting a study like this, which is a study that's been approved through the FDA, we really report every single adverse event that occurs to patients and classify them as serious or not serious adverse events. And we can see some of these adverse events like diarrhea and constipation, even syncope, tremor, dizziness, we think probably were from the immunosuppression. All of these side effects that have occurred from this have all been transient, so none of them have been long-term, and some of them stopped when patients were then off their immunosuppression therapy. And they were classified as mild to moderate adverse events. There were some procedural adverse events, like things like headache, also resolved postoperatively. And one subject reported 2 serious adverse events, and they were related to an episode of status epilepticus, unrelated to the therapy and something that this patient had experienced for many years prior to that, but were classified as adverse events as part of the trial. And we didn't see any adverse events related to the cell therapy itself. Some pretty exciting results on neurocognition and quality of life. This is really the part of the main goals of this trial. The exciting thing about this trial is that it's the first time we're seeing seizure freedom rates like this without having to actually destroy the underlying tissue that we're treating, like we do need to do in a focused way with laser ablation, or like we need to do with surgical resections. And so that's really part of the most exciting aspect of this, is that we're seeing some fairly significant gains in things like verbal memory, visual spatial memory, and importantly in quality of life, which is really the reason we do epilepsy surgery to begin with. So some patients ask, whether or not they qualify for the study. Again, this is like in its very first phases. We hope that soon there'll be larger versions of these trials. At this point, these are the qualifications for these studies. Patients who are 18 to 75 years old, have focal seizures coming from the mesial part of the temporal lobe, have failed 2 medications, meaning they meet the definition of drug-resistant epilepsy. We're patients that were pretty that we really know where their seizures are coming from. Seizure frequency, at least 4 per 28-day period over the 6 months prior to enrolling in the study. And these are often patients that we do consider candidates for other things like laser ablations, for example, or temporal lobectomies. No previous surgery or no previous brain surgery, and then no previous, cell therapy. Those are the exclusion criteria. And so here are the clinicaltrials.gov markers. If you want to ever look this up, you can find a lot of this information online. And thank you. So with that, I'll take any questions. Yes?
So is the eventual goal, once it's all, we get proven out that it's going to be something that's widely available to everyone?
Is that the eventual goal? Yes, absolutely. Yeah, again, we're still in the first phases. It's too early to say, what or how long that process will take, but certainly that's the hope, is that this is actually going to be a therapy that's available that, we don't know, but could potentially take the place of some of the therapies that we currently have, like ablative procedures or resective procedures. And what I'm most excited about is that this could potentially give us an avenue to treat patients that right now we just don't have good treatments for. Yes?
I'm just curious, so I had surgery, so that means I can't qualify for something like this?
Just right now, for this very specific clinical trial portion of this, there are extremely rigid criteria because we're very focused on just establishing the efficacy of the therapy. And once we can establish that, then we can envision a scenario where this therapy actually becomes widely available to everyone, including patients who have had previous treatments. Yeah. Yes.
Do you think that this might ever be advanced to treat patients with generalized epilepsy?
That's a great question. Right now, this is a therapy that we inject into a region of focus. So, at least from my perspective, and I'm not speaking for anybody else, right now I really see this as a way to treat focal epilepsy, and maybe even in a more exciting way to treat multifocal epilepsy. I think that in the future we can conceive of treating networks of disease, and I know Dr. Banda mentioned that in his talk. Sometimes when our concept, we think we've identified a focus and we've resected it or we've ablated it, but truly there's something, that patient didn't become seizure-free because there's something we just don't understand. There's something we haven't quite figured out about that patient's epilepsy and probably in general about how epilepsy functions in the brain. So I think this therapy could, this is again me speaking, could potentially, I would envision it as a way of being able to treat multiple regions in an epilepsy network. Now, whether or not that will eventually translate to more generalized epilepsies, I really don't know. Yeah. Yes. That's a great question. We certainly don't have data yet that could give us those kinds of answers. But I think we could be fairly hopeful because in many ways this functions similarly to how we would expect patients to react to a laser procedure where, we perform those procedures on patients who are 18 and patients who are 65, and we can still get excellent results at 65. But of course, it just depends on the state of the brain at the time and really where the seizures are coming from. Yes? That's a great question. I personally think the immune suppression is one of the hardest parts of the trial because otherwise, procedurally, it's very similar to everything else that we do. But these, being on the medications for a year is something that, some patients do quite well. They don't react in any way to the medications. But for some patients, they can have little things like, constipation, diarrhea, other kind of annoying effects. As far as whether it's really necessary, I don't know the answer to that. At this point, certainly from a FDA perspective and a regulatory perspective, there's no question that I think it's necessary to do now. But, whether or not we'll find that it's necessary in many years, I don't know. I'm also personally intrigued by the concept of, the induced pluripotent stem cell concept because that actually negates the need for that. So maybe we'll see that in the future come out too. Yes?
I'm wondering, within the patients you've had in the study, you treated any that have verbal challenges, not speaking, that nature, and I know you're not tracking it, but have you seen any changes in verbal ability?
In what?
Verbal ability.
Verbal ability. So, I did show, in fact, I'll show it again, some promising results in general with cognition, things like verbal memory and visual spatial memory. I don't think that we would take a patient who doesn't have the ability to speak, and with this therapy, I don't think that it would change that aspect of things. But what we do see is that, ongoing seizures have an effect on things like verbal memory, visual spatial memory. Anti-epileptics can have an effect on those things as well. And so ultimately, both in this trial, but even in our other epilepsy surgery modalities, when we can really have a meaningful effect on seizures and even potentially down the line decrease anti-epileptics, we usually see some positive gains. Yes.
I would really want to try this, but since I have surgery, when do you think that would be an option? Do you think that could be an option eventually?
Yeah. I certainly hope so. It is my great hope, and I am very encouraged by seeing some of these results, that this will be an option. And I think the timeline, it's really hard to tell. It does take years to sometimes to bring these trials all the way to the point where we can then use them, meaningfully from a clinical perspective. But yeah, that is the hope.
I recently got it in June, and then I was told I have 2 years to decide if I want to get the laser, in that same area to help more. Now that I'm learning this, I'm wondering if I should just forget that part and see if this will eventually be available in a couple of years. I don't know. What's your opinion on that?
It's really hard to say because it's so individual to you and to your, everything that's going on and the anatomy and so forth. I would say that the 2-year to laser, there's really usually no time limit to that. But yeah, it would be very, very dependent on you. When you'd be eligible for a laser ablation is what I'd say. So I wouldn't. Yeah. Okay. Yeah.
find something that shows that it's going well.
I'd be happy to talk to you after about your individual scenario. No problem. But yeah, it is really exciting. It is really exciting. And, again, I think it does, I like that there's hope up there because I think it does offer hope for patients where currently we don't have a good option, or for patients even who have had surgeries in the past and we haven't necessarily been successful, maybe because we haven't identified the focus, or maybe because there's more that needs to be treated, but we're not sure if we can do it safely. And so that's where I think some of this would really potentially be a game changer. Yeah, yes.
Maybe in the future you can do another study with people with epilepsy and autism. I myself, I kept my son's, well, not his stem cells. I could have, but I was told it was too new at the time, 20 years ago. But I do have his brother's stem cells, he's 2 years younger, and I have his 10-year-old brother's stem cells and tissue. And I haven't been able to use it. Like, I cannot find, I cannot put him in a study for even stem cell therapy for autism or anything. Everything is very new, everything is done in another country. So anyway, it would be nice one day to test for, do something like this for autism and people with epilepsy. With stem cells, they use however you do them, and then their families.
Yeah, the field of cell therapy or treatments that come from stem cells, I think, is really growing. It's not growing as rapidly as one might think when you look at the news, and some people are advertising right and left that stem cells are a cure to everything. Sometimes we do have to be a little bit mindful and appropriately suspicious of some of those things. But I think certainly there's a lot of potential when we have a therapy and we have a pathophysiological process, actual what's going on in epilepsy, is one where we could potentially correct an imbalance with cell therapy. I think that that's a really intriguing use of this kind of therapy. Yeah. Yeah. Well, thank you all. Yeah.